So what we did is, in Norway, we have a very good oversight over all transplanted patients. We looked at 2,000 patients transplanted, and this was in a period when first there was VCD everywhere, and then there was some years where some regions of the country started using VRD instead of VCD, and then there was, in the end, everybody used VRD. And if we evaluated these treatments, the primary endpoint was 3 months after transplant. So up to that point, it doesn't really matter what time period you're in, because it's the same treatment, it's the same time point, nothing else really happens in this period. It's just afterwards, when it comes to overall survival and such, that it can change from 5 years to 5 years later. So, and we showed that in this totally population-based study, VRD clearly was better than VCD. This was both on the response rates before transplant, after transplant, it was on PFS, it was on OS, it was whether or not they had received consolidation, or whether or not they had received maintenance. So for me, it's a really strong signal that on a population base, VRD is a better regimen. The sort of peculiar thing is that neither VCD nor VRD is approved for induction therapy in Europe. The only approved regimen for induction up till DARA was VTD, which everybody hates to use because it's very toxic. So I think this paper, along with other papers showing the same sort of real-world benefit of VRD over VCD, was part of why VRD as the control arm in Perseus could be approved. Because Perseus, which was DARA VRD instead, was approved last week in Europe, but the control arm wasn't approved. So I think the body of work that many have done on this VRD, establishing it as a standard of care, even though not approved, is important for being able to have used that as a standard in the standard arm in studies now, where DARA VRD is recently approved and can be used when reimbursed.